Hey everybody, Karen Anderson here with Aortic Hope. This is yet another live Q&A for Aortic Disease Awareness Month. We know a lot of people like to focus on one day, some organizations on a week. We bring you an entire month of information because we're gluttons for punishment. No, it's actually a lot of fun and it's pretty educational, and we hope you find entertaining as well. And so today is a really special guest, but before we get to that, click that like button. Click the subscribe button, click the bell so that you're notified the next time we go live, which is actually at 6 o'clock tonight. So if you don't want to have to rely on our less than stellar memories, if we've had open heart surgery, then click the bell and it's going to do the work for you. And so now I can get to introducing Dr. John Martin. So you're with University of Maryland, correct?
That is correct.
Yeah, and we're going to talk about abdominal aortic aneurysm and just abdominal aortic disease in general, because I don't really think, and tell me if I'm wrong, the aorta that's now its own organ. I don't really think that Charlie says to Sam at the area of the diaphragm, no, you can't cross here and cause a disease element. I think it's just one structure, right? And while statistically certain areas have a different prevalence and crossing maybe would or would not happen, I just think that when we talk about the aorta, we really should pay attention to the entire vessel. So
yeah, I think it's really important to do that, because candidly, when you have an aneurysm above, you're more likely to have one below. If you have one below, you're more likely to have one above. So it's all in the same family.
There you go. So why don't you tell everybody a little bit about yourself, since I'm not super great ever at introducing people because I can't remember everything and I don't want to sit here and read. Tell everybody a little bit about yourself, and then we're going to jump right into this.
Yeah, I'm a vascular surgeon by trade, been one for a long time. I trained at Parkland Hospital in Dallas a long time ago. I practice in Maryland, in Annapolis, with the University of Maryland. I am also the president of the Heart Health Foundation, which we'll get to a little bit, that's created a nonprofit Dare to Care screening program that I've run for the last 25 years. And I also wear another hat. I'm the chief medical officer of Butterfly Network, that's built a transformative ultrasound device that's great for screening for aneurysm. So all of my little activities are somewhat related to the topic of today.
That's so wonderful. And I hope we get to every single one of your little activities. So let's start with a big one, the underlying, which is abdominal aortic aneurysms and abdominal aortic disease in general. So first, why don't we just talk about the aorta, and let's explain to everybody what areas are we actually discussing? Where does that area begin? And I'm just going to let you teach everybody from there.
Yeah, and we're going to talk about abdominal aortic aneurysms today. Obviously, they're related to the big blood vessel that really comes off your heart, is called the aorta. And then it obviously is the source of blood flow to your arms, your legs, your intestines, your kidneys. But it basically is the main highway. If you live in our region, it's Route 50. You can pick a highway. Route 66. It's the major highway through your body where all the blood flow goes. And then we distinguish between it being a thoracic aneurysm or an abdominal aneurysm as it goes from your chest, which everybody's pretty familiar with, to your abdomen. And once it's in your abdomen, it splits. So the highway goes to the right side of the world and to the left side of the world, your right leg and your left leg. So we're talking today about aneurysms in that major aorta that's below the diaphragm, below the chest, and right before your legs. And so what's important about that is to understand, what is an aneurysm? So many people say, what's an aneurysm? And the best way I usually use to describe it is, you think about an old tire where there's a bulge off the side. It's a weakness in the wall of the tire. And what happens if you get a weakness in the bulge in your tire? Your tire blows out. Well, what happens with the aorta when you get an aneurysm and the wall gets weak? That can rupture as well, and it does not result in a very good outcome should that happen.
Yeah. So when we talk about abdominal aneurysms, prior to me even having my thoracic dissection, which was almost 10 years ago, this is what I thought. Okay, these are going to be men that are old and smoke and are heavy. That's what I thought. And so these stereotypes, like people with Marfan, really, really skinny, lanky, long arms, all of these stereotypes are just really meaningless, because it's not true that it's only men and it's only the way that I described it. So why don't you explain that a little bit too?
Yeah, and I it's so interesting about stereotypes, no matter what they are, because there's this little element of, okay, what led to the stereotype? And what led to the stereotype that you just said, so it's old fat men that smoke. Is because candidly, if you're a smoker and you're an older and you're a male, you are more likely to have an aneurysm. But it's not the only group that gets aneurysms. That it's really can have an aneurysm if you're a woman, or are man, if you smoke or you don't smoke, if
Mhm.
you're heavy or you're thin. And so the difference is, what is the likelihood that a certain population will have one? And that guides a lot of how we look for things. We try to tend to look for things and screen for things in a higher risk population. But there's another risk factor that's really, really important, and that is family history. So you have a parent or siblings that have aneurysms, you're much more likely to have one yourself, whether you're a male or you smoke, or you're overweight or any of those things. And so I think it's really important to understand that I'm not free from this if I don't have those things. I need to at least be
Yeah.
aware of what the risks are and whether or not I should be screened for one of those.
So from Think Aorta, which I'm sure you've heard of this organization, it's a campaign worldwide. We actually just brought Egypt on, so it's really growing and expanding. And they're basically a sister company. They're the pre-active organization, and we're reactive. So when people think about the aorta and they identify people at risk, then they come to Aortic Hope for their support and resources. So we often say, think aorta, think family, and we definitely press that upon people. But I still think there's this reason that people feel, okay, well, I had a bicuspid valve that created an aneurysm. I'm risk-free from anything else for the rest of my life. And I'm like, not if, your grandfather passed suddenly and they just chalked it up to a heart attack without any type of autopsy. I would say maybe you're not. And if you did develop a thoracic aneurysm, I don't think that you're completely risk-free from an abdominal. I mean, I look at my own family history. My father had an abdominal aneurysm for years, never grew. But then suddenly one day I develop a thoracic aneurysm and I have a dissection. That's how I found out. So again, is there a genetic component with this? For sure. So if somebody found out they had Marfan's or Loeys Dietz or VEDS, do they need to worry about these aneurysms also falling into the abdominal area?
Yes, and the short answer is yes. And I look at it this way: don't worry, do. Worrying is an emotion that you have. Go get screened is something that you physically do.
Yeah,
Because if you physically get screened and you don't have one, you can take the worry beads off the counter and stop using them. And it's
that's right.
important to understand that people that have an abdominal aortic aneurysm, about 20% of them will also develop in their lifetime a thoracic aneurysm. And if you have a thoracic
Okay.
aneurysm, about 25% of those people will develop an aortic aneurysm. And
Mm,
that is because a little bit different than dissection, but in the typical aortic aneurysm, a weakness develops in the wall of the aorta. That
mhm.
weakness is not necessarily limited to just the abdomen. That same pathophysiology, or if you
Oh, we had a little bit of a freeze. Come back.
will,
Okay. Wait,
oh
no,
my gosh, I'm disappearing. That's weird.
no, go back.
Do you
Go
have me
back to
back
what you were
again?
saying. Yeah, go back.
Oh,
Yes.
that's funny because I keep talking. I can't even tell I froze. That's
It's okay.
interesting.
We're very
Um,
much alike. We'll just keep talking. Keep going.
So what happens is, whatever leads to the development of an aneurysm in your abdomen, that same kind of mixture exists for your chest. And so
Okay.
you're not kind of immune from that being a problem.
Okay. All right. So you are not the typical stereotype, but you also don't have family medical history, but you go in because you have a stomach ache and you've been having a GI issue, blah, blah, blah. You end up getting sent for a CT scan. Number one, on that type of CT scan, because people are going to say, are they different than the ones we have for our aorta? Can this be picked up on a CT scan?
Yeah, and the short answer is yes. But I'll step one thing back just to
Sure.
remember. If you have an aneurysm, you may not know it at all. There are no
Right.
symptoms of an aneurysm in your body. So you say, well, hey, I didn't feel anything. I don't notice anything, so I don't have an aneurysm. No, the only time an aneurysm actually produces symptoms is when they rupture. And so
Okay.
so you're not sitting there and saying, well, if I don't feel anything, I don't have an aneurysm. That is not true. I
Well,
also don't
so
want to.
right before we go back to that, let's stick with this for a second. I do read on the pages because before I talk to physicians, I like to read and check the pulse. You saw what I did there. Read
That was well
into
done. Well done.
thank you, thank you. In the pages in Facebook, I read some of the, I mean, truly heartbreaking fear, some of the most ridiculous, and some of the most, incredibly thought-provoking. But what I hear a lot is people do talk about having all of a sudden, once they've been diagnosed, now their belly's pulsating, they feel a bulge. And sometimes you just have to look away because I don't want to get into this answer that makes me sound authoritative because I'm not a doctor. So how do you address when people do think that they are feeling pulsating or bulges or stomach aches? Can that actually happen if it's large enough?
Yeah, so particularly if you're thin,
Hmm.
you can feel people that have a particularly a reasonable size aneurysm, and you put your hand on your stomach, you may feel your pulse. Now
Hmm.
that can be normal or can be abnormal, but I think
Okay.
I've always taken the approach, if you're concerned and you're worried, check it out.
Yeah.
Don't sit home and wonder because it's a simple ultrasound. You don't even need a CT scan. You get a
Hmm.
simple ultrasound that can answer that question. But yes, people can fear the pulse. And many of the patients that I've operated on that have really big aneurysms that are thin,
Hmm.
once you put them to sleep and getting ready to do the surgery, you literally
Yeah.
can see their abdomen doing this.
Wow.
Yep.
Okay. Wow. So again, don't worry, do if you're
Yes.
concerned. And that's a good point too. So whether this is found incidentally from a CT scan or your doctor asked to do an ultrasound, whether you're having it done because somebody in your family had something, so you want to be proactive and just do a look see to make sure everything looks okay or get a baseline. It's not. I guess the first line here, even though we're told in the thoracic world the best is a CT, you can go and have an ultrasound.
Yeah, and it's very simple study, no
Yeah.
radiation, very simple protocol. And it's important to know that the United States Preventive Services Task Force, USPTS, that whole
Hmm.
organization, they
Yeah.
make recommendations on what screening is appropriate.
Hmm.
Now, they define a high risk population that should be screened routinely. And
Okay.
that population is males 65 to 75 who have ever smoked. So that's the group that they flat out say, yes, go get screened. That's an A recommendation.
Hmm.
There are other organizations that expand that. And they look for instance, women 65 to 75 who have
Hmm.
ever smoked. They also look for people that have had a positive family history should be screened. People that
Hmm.
have disease in other areas should be screened. And so
Okay.
you also have the opportunity to take advantage, and in many places, getting screening just because you want to.
Hmm.
And while that may not be recommended by your insurance company, we could certainly have a great debate, and I've debated them often on the value of screening because you're worried. Because candidly, that's a risk factor. If you're worried, my recommendation, not the government's recommendation, maybe not your insurance company's recommendation, that if you're in a higher risk group, if
Hmm.
you're 25, you're not going to have an aortic aneurysm. The risk
Hmm.
goes up with age. Age is a very big predictor. But if
Right.
you're 65 and worried about it, you should be screened, in my opinion.
Right. I think that totally makes sense. So let's go and talk a little bit about uh, when you find out you have an aneurysm, because this is such a different world, because I don't have one. So this is so interesting to me, but so many people do, and my father did. When you finally find out you have one, the numbers game is very different than for those of us with ascending or thoracic descending, where we are always freaking out that we're sitting at 4.8 with a root aneurysm. Like, why won't they do surgery? And this
Look at you. Look at
topic,
you. Now an expert. This is great.
I know. Didn't you love this? Yeah.
Yes.
Well, because I'm sitting at 4.7. You'll find as you get to know me, sometimes I ask a lot of questions that have to do with me, but I'm a good actress and I don't let you know that. But now you know that, so you know it. But this definitely doesn't. I don't have one in my belly. But I have another really good question I just thought of too. Okay. So let's say you find this out. What are the numbers? Because I've seen a 7 centimeter, it looks like a Coke can. What are the numbers in which before some type of intervention occurs? And second question to that, the minute it's found out, if it's a low number, do they also recommend medication like they would if you had it in the thoracic area?
Okay. So let's start. First of all, size matters. It's a
Yeah.
very important thing. So how big, but what's normal? I mean,
Right.
let's start with what does normal looks like. So the average aorta is about 2 centimeters, this big.
Okay.
That's the typical size. When we see an aneurysm that is an aorta that's gotten bigger than that, we start calling it an aneurysm at 3 centimeters.
Oh,
So
interesting.
yeah,
Okay.
so the definition typically is at 3 centimeters, you now have an aneurysm.
Mm-hmm.
And so, but it's extremely rare for a 3 centimeter aneurysm to rupture. I don't want to say impossible, but exceedingly rare, and rare enough that the risk of fixing it is higher than the risk of it
Sure.
rupturing. So
Sure.
once you identify that you're someone with an aneurysm, then it needs to be followed. And
Mm-hmm.
then the question is, how do you follow it? And typically with aneurysms, you follow it with ultrasound. Very simple test. We can see the aorta very nicely, and we follow that with ultrasounds. How often that ultrasound is done is based on two things. First of which is how big is it? So
Mm-hmm.
aneurysms of 3 centimeters, it's probably safe to schedule a follow-up every year.
Okay.
Once the aneurysm gets to be about 4 centimeters, or if that 3 centimeter aneurysm is growing faster, Every
Mhm.
6 months is the interval that's typically recommended.
Okay.
So, but we don't intervene until the aneurysm gets to be 5 centimeters in women, 5.5 centimeters in men, unless the aneurysm is growing rapidly. So
Okay.
it
What's
much like
rapid
yourself,
growth?
wrap more than 0.5 centimeter within a year is faster than usual.
Okay.
And so that would certainly get people's attention. If
Mhm.
it went from 3 to 3.6, also remember, and this is an important thing out there for everybody, there is a little bit of a margin of error from test to test. So we have to be pretty specific. If you want really accurate measurements and how to plan surgery, we do move to
Mhm.
CT scan. So that
Okay.
test that you're very familiar with, we would get a CT scan. But
So
there's always a
interesting.
little bit of variability
Yeah.
in measurements when you do this. But typically, small aneurysm, I follow it. Large aneurysms, I fix it. It's pretty straightforward.
Okay.
Now, is
Now,
there anything I can do in between?
sure. Right.
Is there anything that has been associated with rapid progression of an aneurysm? There's a couple things, one that we know for sure that is, and one that there's always been a hypothesis but not great data on. The one that we know that is if you smoke. If you continue to smoke
Hmm.
and you have an aneurysm, then the rate of growth is predicted to be faster. So
Okay.
rule number one, if you have an aneurysm, the very next thing that you do is quit smoking.
Mhm.
The second thing that people talk a lot about is high blood pressure. And I'm sure that's something that's mentioned with you quite often,
Mhm. Mhm.
because you would think that if my pressure's high, it's going to stretch the wall more, it will grow faster. The data on that's a little bit mixed. I never
Mhm.
worry that much about that because candidly, if you got high blood pressure, I want to control it anyway, whether
Of
or not you
course.
have an aneurysm.
Right.
So the big thing is if you smoke, stop smoking. If you have
Mhm.
high blood pressure, get it treated. But I can't necessarily tell you if you get your blood pressure treated, it's not necessarily going to keep your aneurysm from growing.
Right.
Those are the two big things. The third risk factor for growth, you can't really change, and that is your gender. Women are
Mhm.
actually more likely to rupture than men. And the second thing
Mhm.
you can't change is your age. The older you get, the longer you have it, the more likely it is to rupture. You can't change those two things.
Mhm. Okay.
So if I have it, I tell people, I don't want you to worry about this every single day. I don't want you to sit here and think like there is a time bomb in my abdomen and my
Right.
day is coming. Hard
Mhm.
to tell people that, hard to get them to think that. But what I do want you to do is know that that's something you have to pay attention to. And you do need to come back for regular visits so that we can keep an eye
Mhm.
on it. Because if we fix it electively, you're going to do well. Your chances of survival are fantastic. If
Yeah.
you completely ignore it and it ruptures, well, we can talk about those statistics. They're not so good.
Is it as life-threatening and imminent as having an ascending rupture?
Yes,
It
similar.
is.
So
It's
your
the same.
chances of
Okay.
survival, if your aneurysm ruptures while you're outside
Well,
the hospital,
rupture. Yeah.
yep, you have an 80 to 90% mortality.
What
So that
now?
means
Rupture, it's being different than if it dissects or tears.
completely different. So
Right. Okay.
rupture is the balloon popped.
Right.
So, and there's some complexity to that as well because your aorta runs all the way in the back. It's covered by a tense layer. So that if it
Mhm.
ruptures into your back, you have excruciating pain. And you do have some time, if you can, in many situations, to get to the hospital because many of our
Mhm.
patients do.
Yeah.
If it ruptures free into your abdomen, kind of in the front, let's say we can look at it in simply that way. Well, that's a big open empty space, and most of those patients die. So a third of the people whose aneurysms rupture never make it to the hospital.
Wow. Okay. Okay. That's interesting. Now, is the reason that the aneurysm, I mean, the aorta is smaller, I guess it gets smaller as it travels down. Is it because there's so much blood volume coming out of the heart, so it's wider, or is it really that same size the whole way?
Yeah, it's pretty similar size. It's a little bit bigger in the chest, as you
Okay.
probably know from looking at this, and it tends to get a little bit smaller
Okay.
as it goes down through. But it's not going down to a tiny little thing because generally the aorta right at the bifurcation, and your
Mhm.
aorta typically splits right at your belly button, so that's
Mhm.
where it actually splits. It's
Okay.
about typically 2 centimeters there, and then it goes off to both iliacs, which are about a centimeter to a centimeter and a half on either
Mhm.
side, that go to your legs.
Okay. Now, would you intervene surgically if somebody had a connective tissue disorder?
Those get a lot trickier, and a
Yeah.
lot depends on what their rate of growth is and a number of
Mhm.
other factors. I think one of the most important things that if you have a connective tissue disorder and an aneurysm, go to a specialty center that's used
Yep.
to actually treating a lot of people with that kind of problem because
Okay.
that's a unique animal.
Okay. All right. Here's another question. and I asked this, it's a personal question. So knowing that my father had an abdominal aneurysm, he was choking. I mean, full blown, people making the symbol, I'm choking, because he was laying down in a lounge chair at the pool. I don't know why people try to eat when they're laying down. You're supposed to sit up, but he started choking. And whack him on the back, nothing's coming out. So he needed to have a Heimlich. And my first instinct as the lifeguard's going to do it is I actually stopped for a second and I thought, is this going to like burst his aneurysm? But then I thought, but he needs to get this out. He has to breathe. So, by the third thrust, the thing he flung out and then he was fine. But I'm sure a lot of people, because they have this misinformation in the thoracic world, that if you need CPR, if your heart stops, that you should not ever give CPR to a person who's had a dissection or has had an aneurysm. I'm like, why wouldn't you do that? It's your only life-saving measure. I want it. So I want a big card that says, please do what you need to do to try to revive me. But they have this idea that it's not going to matter. You're just going to crush them to death. Please explain this idea and how this works.
The short answer is you do what you need to do to save people's
Right.
lives, period.
Right.
And so you're not going to crush the aorta. It's a very pliable thing. And you're not going to, it's not like you're pinning the balloon against something that it's going to make it pop. So
Right.
if you need a Heimlich maneuver, first of all, that thrust is more up than back. So
Mhm.
it's a combination of both. And
Yeah.
by the way, for those that don't know it, there's a great device out you see advertised on TV that's really good for that. And I suggest people look for it. It's
Mhm.
really good where you put it over and pop it. It's a great way to pop
Oh,
things.
that's great. Yeah.
Yeah.
Okay.
But the second thing is don't ever think about, and certainly from CPR and someone has a threat. If you don't do CPR, I know what the outcome is, period.
Exactly. Exactly.
So please definitely don't use that as a reason not to do something. And I think I think people that have aneurysms need to be aware, but they're not this frail piece of glass that's walking through that nobody can bump into that's going to shatter. It's not your Waterford crystal that's walking around.
Listen, the people in this community have very wild imaginations, and I'm one of them. So I can say that when you are told that your aorta has 3 flimsy little layers, you start to think, wow, and if I tore through 2, how am I alive by this one little layer? And it is amazing. It's amazing, but that is the strongest layer. But our minds think, if I sneeze, I'm going to die. Just like a pregnant woman, the first time she has to sneeze, you're like, oh, is it going to come out? We don't understand the way our bodies work. And the reality is that we leave the physician's office still not fully understanding in a majority of cases. So even after you've had emergency surgery and a physician says, you're great, I could see you in 6 months, go live your life. A lot of people go home and they are cardiac paralyzed. They just sit and they're like, I don't want to get a cold. If I sneeze, if I walk to the mailbox, if I get a glass of water, I could trip and die. Like everything goes from A to Z. There's no gray area. And that is part of the mental health aspect that we're fighting. So now fully understanding the likelihood of, this is a huge problem, abdominal aortic aneurysms. And I don't think that it's addressed enough. And maybe that's just me living in the thoracic world, but it seems to be as equally as scary. But we do have a lot of imaginations. And I think that's why, we think if you do CPR, it's going to just explode.
It's such an important point you bring out because I can tell you, obviously, taking care of lots and lots and lots of patients with aneurysms, both thoracic and abdominal, is that 3/4 of my job is not the medicine, it's the mental. Because if I send someone out the door feeling like you just described, I haven't really helped them that much.
Right.
Because you want to add more life to years, not just years to life. And I think if people then put themselves in a little box and stop living, then I haven't really helped them. One of the nice things about that I always say, and I laugh a little bit and tease my patients, I said, if you do those things, you're not going to live any longer. It's just going to feel like it because you're going to be miserable. And so live your life, because there's not things that you're going to do short of being irresponsible and smoking constantly and things like that, playing in the street. There's nothing you're going to do. And by not doing exercise, walking, eating, doing those kind of things, you're actually making things worse. So, and anxiety and the emotions that you just described, obviously, what do? They can raise your blood pressure. Those issues themselves are not helpful. And so I think it's important for people to put disease in perspective. I can speak to this as a cancer survivor. I worry about cancer. I can understand the shadow that people live with. I had metastatic cancer. It spread. I worry about it coming back all the time. different worry than yours. So every little bump I feel, is it back? Is it back? That's what people live with once they've had
Yeah.
disease. And I totally can appreciate it. Our job, and you're doing an amazing job of it, let's make you as informed as possible
Yeah.
so that we can minimize. I'm not going to be able to eliminate your worry
Right.
because it
Right.
exists. But if I can minimize
Exactly.
it and put it in perspective for you, you got a better chance of living a quality life for the years that you do have.
Yeah, yeah. I mean, we offer qigong classes, mindfulness classes. We do as much as we can to purposefully give the community tools to ground. And I've said this before, I'll say it again. A lot of what was created in this organization was selfishness into selflessness, because I was freaking out. I go get a scan and I'm the one waiting for the place to open so I can get the report, so I can have multiple screens and look up what words meant, because I just didn't have it in me to wait for the physician to call. And so when I feel different pings and pangs, and still to this day, even though I do all this, even when it's yourself, you get a little nervous. I have to take a couple deep breaths and I do a body scan. I just close my eyes, and the first thing I look for is their pain. If there's no pain, I can really now kind of relax and just kind of go over from head to toe. Well, what was I feeling? What's going on? Usually by the time I'm done, whatever happened is already over. It's past. So I distracted myself by trying to just go through my body. But these are not things that are taught when people leave. These are things that as a community, we're now hopefully teaching people. So another question from me, because I don't know enough about this, this is going to sound silly, but I don't know. When people find out they have an aneurysm, obviously they're wearing their seatbelts. I know that answer to that question, but can they ride a roller coaster? Like, what are their restrictions? Is there any? Because there's restrictions for thoracic patients.
It's a little bit different with abdominal aortic aneurysms. Yes, you can ride a roller coaster. There's nothing I tell my people that they can't do.
Okay.
I think it is, and remember, dissection's a little bit different animal than
Right.
this.
Yeah.
The big thing with dissection is you're splitting the layers of the aorta, right? So that's what's happened with you. With an aortic aneurysm, the typical, all three are dilating out. So it's a little bit different kind of animal than this. But you don't really need to change your life. You can do those things. You can actually enjoy them. And I think it's what's so powerful about what you're doing is twofold. First of which is you don't look like an aneurysm patient. I mean, if somebody walked up to you,
What
they're
do
not
they
going to
look like?
That's the whole point.
Yeah, exactly. So
That is the whole
somebody
point.
said that. Somebody said that. They said, I don't look like the typical face of an aortic dissection patient. And I was like, of course you do, because everybody looks like they could be one. You look exactly like the typical patient.
And what people have in their minds, though, in the community, it's they're much older, they're old smokers, they're
Sure.
all these. It's anybody but me. It's anybody but
Exactly.
me. And
Exactly.
I think that's what's really valuable. But I think maybe again the most important service that you're providing is I wish, and I don't say this to denigrate my own profession. So I wish we had the time in an
Yeah.
office visit and the time to explain all of this stuff in great detail to allay everybody's fears. But at the end of the day, we don't, and we don't often do a really good job of it. And so it's why your organization is so positive. And the most important thing I can say today, more than anything else, is take advantage of what you're providing, because it's an incredible service that you're just not going to get in other places, that you need to take advantage of because it will make your life richer and fuller.
You know what you do have is a copy of Aortic Dissection, the Patient Guide, a box that I can send you for free. And the second book's coming out, and I'll send you a box of those for free too. I'll bring them with me when I come to visit you in beautiful Annapolis.
That would be great.
Before we talk about treatment, which is really important, and then I want to talk about this Dare to Care, I want to check in with Joshua and see if we have people out here that might have questions or just saying hi.
We have a lot of people saying hi. We don't have any questions just yet. I did tell them, don't be shy. Don't be shy.
Just takes one.
Yeah. But Christina, Natalie, Velda, Mark visiting us from England. Tom, very own Tom.
Oh, I was just there in London last week.
Nice.
Just got back.
Velda says, this doc is good with several O's.
Ooh.
Molly just jumped in. Say hi. Hi, Molly.
Hi, Molly. All right. Well, that's wonderful. Somebody will become brave enough and they'll ask a question. And if not now, they will once I post this information in some of those abdominal pages. But really, even the other pages, they just need to know about it because it could happen to them. So I'm very different. Not everybody's like me, and I respect that. But I want to know about anything that can happen to my aorta, because because anything can happen to it anywhere. So the more I know, then the less fearful I might be. An interesting story. So I had Crohn's disease. So I've had it since I was 19. My mom, all of her first relatives, like it's very big in my family. And I went to a retreat once, an all women's retreat, which was life changing for me. And that was kind of where I also realized, all right, so it is a disability. I just looked at it, my life as being normal. I never saw it as anything else. You work with it. You bring a change of clothes in case there's an issue, the whole 9 yards. And I met a couple women in the room that had ostomies, which I didn't even know. I knew you don't want to get a bag. Like it was a stigma. I didn't even know what that meant, right? Like you just don't want a bag. I'll take cancer. I just don't want a bag. I just didn't understand. And I was like, you have a bag on like right now. And I'm looking because I don't know where is it? Is it in their back? I don't know where it is. And they lifted up their shirts and they showed me. Now I am completely awestruck, fascinated. I'm like, is there something in it? I'm asking all kinds of detailed questions and they are like answering. They're like, do you want to see me empty it? Do you want to see me change it? And I was like, well, maybe not that, but I do like just looking at it. Well, lo and behold, 3 years after I had my dissection, I ended up needing to have an ostomy because I had a major complication from Crohn's. I was, so upset, and yet I wasn't scared because I saw it. Now, the nurse came in the room with this apron with these Velcro body parts. She opened up the skin and she had intestines and she Velcroed on a pretend bag. And I looked at her, I'm like, do you have a bag? She's like, no. I'm like, so you don't really know what this feels like to put on and take off. And she said, well, I've tried them. I just put them on my skin overnight. And I was like, okay, but you don't really know what this is like, which I really would have liked to have met a patient, because then I would have seen them standing there talking. I might have even asked, can I touch it? I don't know. I would have probably, knowing me, but I already knew because I saw real people. So going into it, half of my fears were already alleviated because it didn't look like it was that big a deal. And for me, it's not a big deal at all. My life is so much better now because I'm not in any pain. But I've often said many times that I would love if physicians would let's say, Aortic Hope come to their waiting room, have a little table, sit there. I understand there's HIPAA. Nobody needs to know names. But if a patient had come to see me in that first clinic visit, which I was insistent upon riding in a transport chair because I would have died, right? If I tried to walk to the doctor's office, that's what I assumed. And if they had been standing there and be like, hi, I'm so-and-so, and I had an aortic dissection and it was a year ago, but here I am and wanted to provide you with information, I probably wouldn't have heard anything else they said because I would have been awestruck that they were standing upright. That's the simplest thing I needed to see to give me the hope that, holy crap, like this person, they're standing. I probably would have left on my own and tried to walk out the room. And I just think having a person who's very similar to you, being able to talk about their experience to all patients and even to caregivers, it's a life-changing experience. It really is.
Well, there's nothing, I smile a little bit because my very first patient was my grandfather, when I was still very, very young, wanted to go to school. This is before college. He gave me $1 bill for changing his colostomy bag and said, I am your first patient. So I have very fond memories of that. And the second thing that you said, which is so funny, is that when I trained at Parkland, it was a big trauma center. So we very often got gunshot wounds and stab wounds. Yeah. And so often, kind of that feeling in the community, they would look up at me and the only thing they would say to me, whatever you do, doc, not the bag. And so it was very much around this, God, whatever you can do, please avoid this, as opposed to, well, sometimes the alternative is much worse.
Right. Exactly.
The third point I want to make is I really would like to tell you to stop standing in lines to get new disease states because you've had enough. You've got more than your share. So you can stop anytime now. You've got more than enough at this point.
I often say, stop. Can I stop proving myself? Can I just have a day where I do nothing and just, I'm going to write a book and the working title is Living with Bad Genes and Not the Kind You Wear. Because look, this gene's already in me. I've got, I feel like cardiomyopathy gene. Like that was fun to find out after my father passed away suddenly. I was like, oh, that's lovely. Now let me look at, it's like it gets to a point where you just have to laugh about genetics. I look at everything very from a scientific standpoint and just looking at human beings in general. And I tend to sit back and pause and just look across big crowds of people, like if I'm at Disney or, outside at a concert. And I just think, God, how many of you right now have an aneurysm and you don't even know it? And that it freaks me out. But then I think, and how many of you in here have some wrinkle in your DNA and you don't know yet because it hasn't come together, and it will show you. And that's just part of being a human. Just is.
Well, one of the things that I think is so important for people to understand, you can't change your genes, at least
No.
not yet.
No.
But you can
Yeah.
change the way you deal with what your genes give you. And
Right.
to have the kind of positive attitude that you have, and to look upon, the burdens that are placed on any one of us in
Yeah.
a very different light. It's all the difference of whether you become a victim to what you have or you become the conqueror of what you have. And when you become the conqueror, your outlook on life is completely different.
Yeah.
And the people around you are completely different. And then you inspire others to follow in that pathway, because it's easy to feel like a victim, to be angry at the world. Why did I get
Oh,
this?
yeah.
But it's not a productive emotion. It just doesn't help. We all go through it. We have
Yeah.
our moments, but I think if you turn it around like you have and channel this in a very positive way, and I can tell you, I try to connect patients with patients. Another big one, for instance, in vascular disease is amputations. There's a lot of people think if I lose my limb, my life is over. Well, it actually isn't. And actually, there are great things that you can do. And there are people, and I've had people in my 90s who I used to always have people call. She's running around like she's 20 and
Right.
she lost a limb. You can do this. You can have the right kind of attitude and have a real full life going forward. But it all
Yeah.
starts with knowing what you have,
That's
get
right.
it treated appropriately, and then do the right things once you know that it's have to make sure that you stay on top of this.
Absolutely. And you bring up a good point. We do some collaborating with Kim McNicholas, and she is with The Way to My Heart. She does a lot of work, PAD. And I kind of learned from her that a lot of that can stem from having some issues. And does that stem from the abdominal area that you
So
might end up having peripheral artery disease issues?
yeah, it's a little bit different animal, but they all kind of fall within the same class of affecting your blood vessels. In one situation, your arteries get bigger than they should be. In another
Yeah.
situation, they get clogged, and obviously things are more narrow than they should
Right.
be. And that cuts off the blood supply to things. And they have very similar risk factors: smoking, high blood pressure, high
Yeah.
cholesterol, diabetes. It's the dysfunctional cousins that live together to try to make your life a little bit miserable.
Right.
And so I
Yeah,
think that that's important.
she's a huge advocate for whatever you can do to try to save limbs. Let's look at a million different options and use that as the absolute life-saving option if need be. So so we've been talking a lot with her, and it's just interesting how everything comes together. And that's why I think that as as a country, as just as globally, if we all just collaborated more, everything then gets covered. There's a road for everybody to travel, which really serves the purpose. So let's talk a little bit about, now that you have an aneurysm, and we know that we may or may not use some medication. Probably it's going to be a lot of monitoring medication if you have blood pressure issues. What are some treatment options? What do we have available, and when?
And then there's the evolution of this. So once your aneurysm gets to be about 5 centimeters, if you're a woman, and that's literally because your aortas are smaller in general, and 5.5 centimeters in men, with some caveats.
Yeah.
Then there are essentially now 2 major options on how to fix them. One is the kind of classic way in which we fixed aneurysms forever. You make a big incision in the abdomen, you open it up, you cross clamp above and below where the aneurysm is, and you sew in a tube, a graft, if you will, to basically replace where the aneurysm is. So the blood flow goes through the new graft instead of out into the aneurysm itself. It's a pretty big operation, very successful, but a big operation. 1 to 2 days in the ICU, 5 to 7 days in the hospital, and typically, a month to 2 of recovery. It's a pretty big swing, and you have to have a good heart and good kidneys and stuff to get through it. We evolved more than a decade ago a new technique, which is very similar to the way they fix pipes these days, is we sneak in on the inside and reline the aorta with a minimally invasive approach. So literally put the tube in from coming up from below and reline the aorta. That's called an endovascular aneurysm repair. And there's a
Okay.
lot of nuance around it based on the configuration, the size, shape, and the nuances of the aorta itself, because it not only typically gets bigger this way, but it
Mm-hmm.
tends to get bigger this way.
Okay.
And so it doesn't stay perfectly straight the whole time. Sometimes you got interesting bends and turns
Mm-hmm.
that make navigating all that difficult. But that operation, much less invasive, and many of my patients who I have that repair go home the next day and have a much shorter recovery because it's too little incisions or even no incision at all at the level of your groins on both sides.
Mm-hmm.
And so much less. There are some anatomic restrictions on when you can get one versus the other, but in general, the majority of aneurysms these days are fixed with the minimally invasive approach versus the open approach. The difference between the two longitudinally, though, is
Mm-hmm.
important to recognize. When you reline it from the inside, there are a number of factors that can then keep that aneurysm pressure within the sac. There's a bunch of little blood vessels that come off it, and come off the aorta, and not all of them, get clotted off when you do it from the inside. And so sometimes you can develop that are called endoleaks. And when we say the word leak, it scares everybody. It says, holy smokes, my aneurysm's leaking. Well, it's literally leaking inside. It's contained within the sac. But if that sac continues to pressurize, even though the majority of the blood flow is going through the tube, some of it can be out in that sac, and the sac can keep going and rupture. So
Okay.
it has to continue to be monitored afterwards. You can use ultrasound and CT to do so. With all that being said, what would be wonderful and what we've never been able to accomplish is, can I do something once I have an aneurysm to stop it from growing?
Wouldn't that be amazing?
Because we know already that small aneurysms don't rupture very often.
Mm-hmm.
Ever. Big ones do. If I find it when it's small, is there something I could do, something I could take to keep it from growing? And
Yeah.
we've been on a hunt to look for that. We
Mm-hmm.
used to think that you could try certain medications, blood pressure medicines that would help. That didn't work. We tried antibiotics because there's some inflammatory changes that we know are part of aneurysm. That
Mm-hmm.
didn't work. So
Mm-hmm.
we've tried different agents along the way, none of which.
Oh, no, come back.
Help.
You froze again.
Did I
Okay.
fade away again?
That's okay. You tried
I think
numerous agents that didn't work.
none of them worked. And so
Right.
we're stuck today with you got a small aneurysm, I watch it, it gets big, I fix it.
Yeah.
There is a little ray of sunshine sneaking in. The clouds have parted a little bit, and there's a ray of sunshine coming in, and that there are some experimental studies going on right now with a biologic way in which to actually solve this problem.
Mm-hmm.
The wall of aorta has a substance called elastin, and it functions basically to be kind of like the rubber band, if you will, in the aorta. The problem with elastin is it breaks down over time. And what happens with aneurysms, it's a much more active process, and substances in your body called proteases break it down faster, so the wall gets weaker. So if you will, the infrastructure of the aorta gets weak.
Mm-hmm.
There's an experimental study going on now where there's an agent that's delivered through a balloon in a minimally invasive approach to the wall of the aorta and jumps on that elastin and acts like a scaffolding. So it cross-links the scaffolding together and it stabilizes it. And there's some really encouraging early results in very preliminary study. This is all pre-approval stuff. We're sharing with your guys a window into the future of what may be coming. And that is, in those early studies, it's either slowed or stopped the growth of the aneurysm. And if that's the case, and you could slow it dramatically, and in the early studies, over 10 years of slowing the growth, you may keep people from ever needing to be fixed or prevent them from rupturing. Really important to tell everybody, this is still early phases, but really encouraging results. And, so we may see in the future for the very first time that if you have a small aneurysm, there may be a treatment that could ultimately result in you never having to have one of these other bigger operations. So we're all pretty excited about what the potential of that might be.
It kind of sounds like it's almost like a medication glue, is something that's a temporary, I guess. We'll know how long it lasts at the end of all the trial, that just kind of coats it. And then, so it's like you get in, you do it, and then you get out. So you're still having to go into vascular, which is preferred over being, filleted open, basically. But you're doing something that is not putting a stent in that has the risk of an endoleak. And that looks like it really could buy somebody a long amount of time before they would ever need any intervention.
And I think what makes it so exciting for me as a surgeon is it's so hard to tell a patient, oh, by the way, you've got this bulge, it's an aneurysm. The problem with it is it could rupture. And what I'm going to tell you to do is every 6 months or every year, you're going to come back and we're going to keep watching to see if it grows. And
Yeah.
so there's the anxiety of constantly
That's right.
seeing this. Now, time will only tell just how good this is. But, if I can then tell somebody, you know what, I've got a treatment now where we're going to slow this thing down dramatically so I can lower the temperature, if you will, in the room of your level of worry, then that's
right.
really exciting opportunity for us.
That's
And
huge.
I think it's kind of what we've been looking for,
Yeah.
just haven't been able to find yet. So I'm really, really excited about it.
What would be cool is if it could eventually be used on thoracic descending, because my guess would be is this, you're not going to be able to do that in the ascending because I don't know, you can't stop the heart. I mean, I don't know it seems too much in my head for me to think about, but it's not like you can, to stop the heart, you're already cracking the chest open. You might as well just fix it. But I would wonder if you could go all the way up somewhere. I don't know. I think by too close to the heart, it becomes too tricky. But for right now, this is still big enough news that this might be on the horizon. One step leads to another.
Yeah. And I think, for instance, you think about, okay, if close to the heart, what are you going to do? We now put in new heart valves percutaneously.
True.
So
That's right.
we do that while the heart's beating. We deploy this thing. So I don't think it's too far fetched. Listen, we don't know yet what the potential of this is, but the preliminary stuff in their first to man trials were pretty exciting. And we'll see. Exciting. And I think, like any new technology, we'll learn over time.
Yeah.
We'll know who's best served by it. What are the long-term results? What's the best way to monitor afterwards? But I think for the first time in my 40 years, I now, know in practicing medicine that there's something really exciting for people with small aneurysms on the horizon.
Very exciting. I mean, I've seen changes happen just in the medicine in the last 10 years. When I dissected, I was told I would be lucky if I had 5 to 10 years to survive. They were still showing those old stats. So you just give things enough time and the technology, happens. And this is incredible. So I hope that you'll keep us posted so we can let other people know what's going on and keep them posted. But it does sound very promising. That's really exciting.
And I think the important thing always is to remember, what do aneurysms typically do? They grow. Right. What would we like to stop them from doing? Growing.
Exactly.
So that's where the hope comes. Yeah.
Right. Before we get into the last part, which is your Dare to Care program, because I'm really excited and I hope to join you on the road with this, I want to just check in with Joshua and see if there's anybody else who's joined or has any questions.
Well, we have some questions.
Okay.
One person says, my father had an abdominal aneurysm repair. Is there any correlation to my type A dissection? No other genetic issues?
The short answer is yes. But the real question then becomes, what does that mean for you? And that is, if your father had an aneurysm and you have a dissection, you got to make sure that on regular intervals, and some people say it's every 5, some people say every 10, there's some nuance to it, but you make sure that you make sure that you obviously don't ever develop an abdominal aortic aneurysm. Family members with first degree relatives should be I tell my patients, and it may be more frequent than, but you will tell by the nature of Dare to Care, I'm a pretty proactive kind of person. This every 5 years. If you see nothing after a couple 5-year periods, you get to be, for instance, 70 or 75 years old and you don't have an aneurysm, you're not likely to get one. But people with a family history and you're young, then I keep an eye on those folks because I like to know what's actually happening to them.
So it's just a matter of having that conversation with your physician, making sure that they're aware of the family medical history, and then just asking them to add in a CT of the abdominal area, right? I mean, you're in that machine so quickly. Or if you're doing an MRA or an MRI like I do, I just have them go chest, abdomen, pelvic, and I'm there all day long. They serve me lunch. No, I'm kidding, but it takes a lot longer. But yes, I do ask them to add that area in, but okay, sorry. What's the next question, Josh? But thank you for that question.
Yep. And we have another one here, follow up. With a type A repair with a managed type B to iliac, if there were a further dissection, where would it most likely occur?
Ooh, that one, the kind of nuance of that is really looking at the anatomy of where your dissection is itself. That's a pretty nuanced, very specific to your particular pathology to answer that question. But when you talk about extensions, the extension of dissections can go kind of 2 different directions distally. They can either go down in your iliac vessels or they go out into the vessels that go to your kidneys or to your intestines. But there's a lot of hypotheticals into that, then it would be very specific to that. You know what I tell people that say, as you start thinking about things like that, I tell them, this is what I want you to worry about and what you look for. Don't try to overthink some of this stuff, because you can tie yourself into the knots. The what ifs are big. It's more important to pay attention to what symptoms do I need to worry about, and if I don't have them, great. And what are the other things I need to be doing to make sure, control my blood pressure, make sure I don't smoke, what's my cholesterol, control the things you can control, try not to worry about the things you can't.
Yeah, 100%. Don't worry, do. I wrote that down twice now.
I like that. I like that.
I like it. All right.
Is it very common to have pericarditis after an aortic repair? Had a type A dissection and 4 pericarditis since.
Well, I can tell you this is one from personal experience. I know what you felt, because I've had pericarditis twice myself. See, I'm revealing, like you, Karen, way too much about myself. It's not uncommon after having chest surgery, if you had an open repair, to actually have some of those inflammatory, there's a specific name for it, it's Dressler syndrome that you can see. So not that uncommon. Doesn't necessarily mean you're ever going to get it again, but somebody that's had pericarditis once is more likely to have it again. The weird thing about pericarditis, and for those that don't know what that is, there's a sac around your heart called the pericardium, and you get some inflammation in that pericardium, and sometimes you get some fluid collected in there. Like any area that's inflamed, when you hit it, it hurts. Well, every time your heart beats and it bangs up against the pericardium, it really hurts. And so when you lie down flat, it's incredibly uncomfortable. And you can always tell people that have pericarditis, because you'll see them leaning a little bit forward. And think of it like a cherry on a stem. What they're trying to do is position their heart just in the middle of that sac. So when it beats and it's expanding, it's not hitting the pericardium.
Yeah.
The good news is usually medication, a pretty simple one, Indocin, actually makes it better over time.
Right. It's something I don't have. So
there you go.
Yeah.
Here we go.
It's great.
And also, there was a comment there when you were sharing about having the opportunity to meet somebody bedside post dissection. And Natalie says, oh, I lost it. This is so true, Karen. I really hope we get there one day to have someone showing up for the dissection survivors in the hospital. Agreed.
I'd love that. So I know that Mended Hearts is a program that's been around for like 100 years, and people become accredited and trained pre-COVID to go into the hospital when called by a physician in a hospital that utilizes Mended Hearts. And then they also train people to talk to family members and patients on the phone. And then once we hit the COVID world, it was all via iPad, because if you never went to the hospital during COVID, as I did, these like robotic iPads come over to your bed, and then the doctors are on there because nobody was coming into your room, and you could talk to anybody through this pad. It was freaky and scary at the same time. So now we live in this era where I think they're starting to make more in-hospital visits. My only thought to the in-hospital would be that immediately once you're first waking up and you're just like, I'm in a chair and I don't know what happened to me, it's not an effective time to meet with somebody. I think that either if you were going back in with a scheduled surgery, that might be okay, but definitely in clinic. First visit in clinic, I think, needs to include seeing not only your physician or your surgeon, but seeing somebody that's a social worker or a mental health professional to do a check, because not a lot of people recognize PTSD symptoms, and they could be a couple months in, 6 months in, and they're still having nightmares and they're not sharing it. So I that's my personal opinion. And I think meeting a community member would also, it would rapidly enhance their recovery time. So hopefully we see those changes coming. That would be the goal.
Yeah, and Karen, I couldn't agree with you more. Acutely in the hospital, there's so much going on and there's so much to process in that time period. And you won't retain it.
No.
Once the dust clears a little bit and you've survived, so you've got that kind of behind you, and you're in the clinic, it's the perfect time to connect with somebody within the community. And I think one of the big things your organization is obviously on the road to do is, how do you get in each of these big aortic centers around the country? And you start with obviously the biggest places doing the most, and then you work your way down to smaller places.
Right.
And because of telemedicine and stuff, we have a great ability to communicate with people around the world in doing that. And I think it's a great service. And I think every aortic center and every aortic surgeon should try to provide that to their patients. I think it makes a huge
2025 initiative. There it is, writing it down. Oh, okay. What's next?
Because you need something else to do. You are not doing
else.
enough. You clearly are bored and you need more stuff to do.
I was going to write my book. No, that's going to happen. That's 2025. But I do like, we have tried so many initiatives. People don't realize how many things we kind of start as a beta test, and it might happen. But then we realize, is this really going to prove beneficial at all to somebody? So then we just don't do it again, because we did it. It was fine. But something like this would be very beneficial. It would be so huge. Every time I think, I wish that happened to me, I know it's beneficial because I know others are thinking the same thing. So, yeah.
Very true.
All right, Josh, anything else before we get into Dare to Care?
Good nuance. Thank you.
Okay. All right. Very good. Let's move into Dare to Care. Please explain to everybody your nonprofit and what you're doing with that.
So 25 years ago, and I think I'll go through this quickly, I came in as a vascular surgeon to see a patient with a ruptured aneurysm, as a matter of fact. And unfortunately, that patient passed away in the emergency before I ever had a chance to do anything. And before I left, I was asked to see a patient that had a stroke and had half their body was paralyzed and had a critical narrowing of their carotid artery that I could have fixed if found it before that happened. And then, if that wasn't bad enough, was one of those nights somebody came in with a cardiac arrest, ended up doing CPR to try to save them. And as I was driving home, I was kind of frustrated and felt like I'm on the back end of disease. I don't want to be there anymore. Yeah. So literally came in the very next day with the idea of a program called Dare to Care, and CARE standing for carotid arteries, abdominal aortic aneurysms, renal artery stenosis, and extremity artery disease. That's the PAD element. I'm going to go out in the community and screen people. And what I'm going to do different than some of the other screenings that you see out there like Lifeline, I'm going to make it free. And I'm also going to make it with education associated with it. And I'm going to open it up to the community and start now. And we targeted everybody 60 and older, everybody 60 and older, anybody 50 and older with risk factors, and ultimately 40 and over with diabetes. Fast forward 25 years, we screened 70,000 people in my county alone. We've set up programs around the country and around the world. And what's important about the disease is not only have we found a whole host of people that have aneurysms early that could follow them and aneurysms that needed to be fixed, but about 48% of the people had some disease noted, and 2/3 of those were not on the right medicines like an aspirin and a statin for having plaque or aneurysms in their body. And so it's had a huge impact on the mortality of these patients. It's changed the way people practice medicine. It is against what the recommendations are of the task force. I totally understand that. But the task force recommendations are for the general population. I'm not screening the general population. By the fact that we find disease in almost half the people, it's clearly not the general population. So it's been a very rewarding approach. I think it's something that we will continue to do as long as we can continue to raise money to do it. And maybe of all the things I've done in my career, what I'm most proud of.
Okay. We're looking to join you on that mission. I love to talk with you. We're going to talk offline. I think that's amazing. And I know there's been lots of people who have thought about doing that. And then what happens is they'll go to the inner city, or they'll go someplace where access is not easily available, and they'll screen. You have this. Okay. Next. I'm like, well, what did you just do to that person's day? You gave them really bad news. And either they don't fully understand what they have, they don't have access to the follow-up that they're going to need to schedule that service. That healthcare journey ended right there with a potential diagnosis. And so that's a lose-lose situation. So to be able to have an opportunity to be diagnosed, to learn about it, to understand, and then to have a journey that they can go on, the steps they need to do to properly begin that journey to take care of it. That's, to me, it's so important. And then if we can get resources to people afterwards, would also be equally as important.
Yeah, we connect all the results, go back. We do no self-referrals. Everything goes back to their primary care doctor. And if they don't have one, we find them. And that's the way it should be done.
Perfect. Yeah. All right, I'm going to do one last check-in with Josh. Anything we need? Anything we got?
We have a couple statements here.
Okay.
I have it highlighted. Mark says, I'm going to have to drop off. See you next week at Edinburgh, Karen.
Okay, looking forward to it.
Right. And LM Sanchez says, we are the music makers, and we are the dreamers of dreams. Sometimes our worst nightmares.
Okay, Willy Wonka. I know where that quote came from. I know that quote well.
Hi, Donna. Donna asks, where is Dr. Martin located? Annapolis, Maryland.
Yep.
Excellent Q&A. Right. Thank you. Dare to Care.
So,
love it. Go, Dr. Martin, go.
Dr. Martin, this was wonderful. I'm going to absolutely ask you to please consider joining us again, and we're not going to wait a year to do this. Definitely want to talk about this. I think it's important, and to It's going to help bring a few more patients. Let's get some more abdominal patients into the fold here, and let's get the other patients educated about the potentials that do exist with their entire aorta. But thank you so much for taking the time to talk to everybody today.
Well, it's been a privilege, and I am so incredibly impressed with what you're doing and humbled by that. And you're an inspiration to all of us out here that try to practice.
Thank you. And thanks for sharing this potential new, who knows what that could be coming down the pike in the future. We love knowing about things that could happen. I know, fingers and toes crossed. That would be amazing for a lot of patients. Hey, everybody out there, click like, click subscribe, click the bell. I got another one at 6 o'clock and you don't want to miss it. And share this, because I guarantee you there's somebody out there that's going to get something out of this today. You're going to educate them and it's going to be potentially life-saving. All right, everybody, till the next time, we'll talk to you soon. Thanks again.